Welcome. My name is CJ Floros, and I am the COO of Laudio. And today we're really excited to have Craig Williams, the Chief Operating Officer of Beverly Hospital, part of the Beth Israel Lahey system here in New England, to have a robust conversation that we're really excited about. Craig is a veteran in healthcare administration, serving executive roles at St. Elizabeth's, Tufts Medical Center, Mass General Brigham, and has a vast amount of knowledge in operational leadership that has served him well over the years to achieve great outcomes and success. And I think, given our current state and his experience has served him quite well in navigating these uncertain times. Craig, thanks for coming with us today and having this discussion. We've known each other for a few years, and I've really been excited for this day to come, because I know that given the times that we're at, and given Boston in particular being one of the first areas geographically to kind of get hit, cut their teeth, and really have been thrown into the fire, it's great to have you to kind of get some insights and learnings on how does this impact things operationally? What were some of the learnings? So thank you for coming.
Sure. Thank you so much, CJ. It's always a pleasure talking to you, and I'm looking forward to our discussion today.
So let's jump in. I think first and foremost, what all of us want to hear and learn from each other, because I think it's one of those situations where you feel like you're a little bit on an island. You went to war. You don't have a whole lot of collaboration with people outside your own bubble, particularly when Boston was one of the first to go in. People want to hear what you learned, given the current environment with some of the operational challenges that emerged. What are some of the learnings that came out of this for you that you now look back a little bit that immediately came to mind?
Yeah, I would say that there was a tremendous amount of opportunities to learn. There's still things that we're trying to learn on a daily basis, right? We, as just in the past couple of weeks, we've reintroduced visitors back to our inpatient operations, and that's proven to be more of a challenge than you'd expect. When we when we walk around and do leadership rounds and talk with our colleagues, many of them say, boy, it was so nice when we weren't here for visitors. Patients were very engaged in their care. As all of the rules start to change on a daily basis, we continue to learn about how we best can engage with our patients and their families. And I think there's a real opportunity to continue to learn there. I think what's been, as I thought about our discussion today, I'd like to think that we've really stuck to many of our strategic priorities, and then think about, how does the new normal actually fit in with those priorities? So obviously we were very focused on improving our patient experience, improving our quality and patient safety. Colleague engagement is incredibly important to us. And then, financial performance sort of comes out of all of those things, hopefully. I'd say from a patient satisfaction and engagement, we're seeing right now with the move to virtual that we probably need to spend a little bit more time getting to our patients to engage with us through the patient portal. There's some real opportunities to communicate proactively that we're not able to utilize today in an optimized way, right? So, about 35% of our patient population is enrolled and actively using the portal. And that allows us, we can actually, we can set up things to know when they're hitting the actual campus. We could communicate much more proactive around our visitor policies if we had higher numbers of patients using that portal. So that's something we're really working on as a strategic priority for us. It'll really help with patient queuing, just a lot of real opportunities that we're missing on. I think from an engagement perspective, the other thing from an employee engagement perspective is really, how do we continue to support the emotional needs of our colleagues, right? Luckily for me, actually luckily for the patients, I don't face patients on most days, right? I'm not a clinician, so I'm not actually involved in patient care, and thank God for the patients. But for the colleagues, when I walk the floors and talk to them, I can see that, this was a really painful and challenging time for them. The rules were constantly changing, and we did our best to communicate, but we definitely learned that there was real opportunities to do a better job of real-time communication. And that's not sending an email. It's getting out in the floors, talking to people, having a strategy on off shifts. It's really important. And the work that they did, deserves that, right? We owe it to them to really give them the most up-to-date information on what's happening and why. So I think that's really what we're working on. I think it's getting back to our strategic plan, the goals of the organization, and then thinking about these external changes that have happened and how does that fit, right? I still think the goals we have as an organization fit in the new normal. Um, it's requires some more focus.
So interesting with telemedicine. It's something we hear all the time, right? And the stats are all over the place. 2,000 visits. 1 month I went up to 20,000 visits, right? And I think everyone, for the most part, is collectively saying, you know what, this is a change behavior that is here to stay, and also very surprised with regards to the depth and breadth of type of service that can be positively conveyed. It's no longer just strep throats and rashes that are on telemedicine. But I'm sure there's some challenges that come with that as well. And just in terms of operationally, regarding having patients on telemedicine, how does that in fact impact some of the other areas of the system, and does it?
Yeah.
And if you have to think about these things.
Yeah, it's amazing. So I just heard a stat that, in 2020, there'll be 1 billion telehealth visits this year that, and that's probably, 100 times what it would have been if this hadn't happened. And much like, my kids in school, all of a sudden they went to a complete virtual environment. And I'm sure the teachers, there's probably things they could have done better, right? We did the same thing in healthcare. I mean, we had been trying to get traction on telehealth with the payers and get reimbursed for telehealth. And unfortunately, much of what happens in healthcare ends up being driven by the reimbursement environment. And so, many of our providers wanted to engage. We knew patients wanted to engage with telehealth. But because that wasn't going to get paid, there was really no incentive for us to really move a lot of folks there. That happened overnight, and we went, right? And so what I'd say now is, when you just flip on a switch like that, you clearly are not optimizing that switch, right? And so now we're trying to understand, as we're bringing back, exception-based inpatient visits, how do you take a provider? And so, we employ about 30 primary care physicians here in our little system in the northeast corner of Massachusetts. And we're trying to think through, how do we optimize their day, right? What percentage of their day do they spend doing virtual visits? When do they see their inpatient visits? Is there some sort of mix of the most efficient way to provide that care? And we have a couple of different studies going on in that to really understand how we maximize our providers' times, how we use our advanced practice providers, how we use staff in the practice. I think many people would say, oh, we've gone to completely virtual care. We don't need as many medical secretaries or medical assistants. But what we found is that there's a lot of pre-work that those colleagues need to do to even get people, facile what they need to do in terms of virtual care. So that's kind of from a provider perspective or thinking through the physician practice. From a hospital perspective, if you look at our visit numbers in terms of what we're doing in primary care, we were at like 95% throughout the pandemic. The funny thing was but the vast majority of that was just happening virtually, right? Yeah. So, we shut all the bricks and mortar. The thing that we saw immediately is that our lab testing and our radiology, here we have all this outpatient, quote unquote, volume that's happening in terms of visits, but it wasn't generating those downstream ancillaries. And, clearly I think that has an effect on hospital financials, obviously, in terms of matching the amount of people that you need doing those jobs to what the volume actually is. I think, it's also, there's clearly a piece of clinical decision-making that can't happen because that data is not there. But then also definitely some overutilization of some of those things. And so, that's really what we've been trying to do as volume starts to come back and still seeing pretty robust virtual care, how do we match our resources with what we think volume is going to be?
Well, I mean, I think you bring up a
That's
good
what we're
point,
working
right?
on.
Because there's additional behavior changes that are needed, right? Because if they're coming into a normal visit within the hospital and then require some lab work, well, just go downstairs or around the corner and go get it.
Yeah.
Now, virtual, it's that added step of bringing them in and making sure that happens on the follow up and so forth. But
And the amazing thing is a system like ours, we have some really optimized places where patients can just walk in and get lab work done. And a lot of that's happening in virtual. But when you think about from a social distancing perspective, we almost can't have those people just showing up right now, right? We need to keep them safe, and we need to keep people distance. And so we've actually just tried to launch overnight having self-scheduled lab so that we would at least be able to say, okay, here's our lab slots using Epic, using the patient portal, allowing people to actually schedule in those lab draws. And that's something that's just had to happen in real time.
well, I mean, I think you can see that this is. I think there's a lot of good that's going to come out of this. You know, the
Yeah, I agree.
struggles and systems having to adapt, and people within the systems needing to adapt and change. But in the end, I think we'll find ourselves in a much better place, and it's an area that I definitely want to talk to you as we get into the conversation. One other thing, hybrid workforce, remote workers. Certainly, we saw a lot of this across the country, whether that's rev cycle or different areas of administration being able to work from home. And what we've heard, hey, some of this we're actually going to keep. We found them to be able to be more productive. We found that it actually worked out better for us. We may need less brick and mortar office space and so forth. How did you all experience that at all? Did you have many working remote, and did you move them all back now? Are some still working remotely? Do you see in your particular case that being something that too will stay or not?
It's funny. So, now this is my first time working in a true community hospital, and we have some many long term both leaders and colleagues here, and I think with some really old school approaches, right? And so initially, the idea of people working from home was, oh, they're just going to be folding laundry and washing the kids all day and not getting anything done. I think it's been a really good case for us, right? We sent pretty much all of our, administrative functions off-site. And those folks are really productive in terms, I think that, from a meeting perspective too, being able to use things. So we use Google Meets here, which is much like Zoom, which we're talking on now. And, we never had a video conference call pre-March of this year. And now, we actually started to bring back my leadership team meeting. People really wanted to meet in person. And what we found is between some people working off site, people wearing masks, not having the right materials, we actually have moved that meeting back online after trying it twice. Mm-hmm. And so I think that there's definitely more efficiency during the day. What we're also trying to deal with is, how do you get people to appreciate that, right? Because there's a lot of folks that just believe half of leadership is just showing up. Mm-hmm. And so you're showing up virtually, what does that mean, right? And I think that that's something we'll continue to work together as a leadership team to understand. I think that there's more opportunities for more work to happen off-site. I think, we actually looked at, we're part of a system, right? So we're now part of Beth Israel Health. Before that system came together, there was a system called Leahy Health, which was sort of Northeast Massachusetts. And as that system came together, there was primary care and specialty practices of each of those legacy systems that overlapped our geography, right? So here in Beverly, I think I have 6 primary care practice sites that belong to 3 legacy systems or organizations. And so what we're really now looking at is, if you think about what's gone to virtual care, what do we need for bricks and mortar, what do we need for practice sites? There's a lot of work happening around how we set up in the future. I wouldn't want to be in commercial real estate right now because I think that is completely changing. But I guess, every industry is facing challenges and change. And that's the one thing that I think is going to continue to be consistent is that things are going to change, right? So we're working on that.
Yeah, there's no doubt. And I think it really did. These last few months have really shown, when we look at each system and each hospital, leadership and where the strengths and weaknesses are throughout the organization, whether it's at the front lines or at the C-suite level, and just the ability to communicate well with one another, the strength of leadership teams, how long they've been together, that they were aligned and be able to get through this process. And I guess with that being said, it sets up kind of the question of.
Let me interrupt for 1 second, though, because
Sure.
I made me think of one thing. And, I'd say, when you're in the pandemic, right, we go to our hospital incident commands management structure.
Mm-hmm.
And that's a management structure that obviously I have something wrong with me because I really enjoy that, right? It's a command and control structure. You can make decisions rapidly. And so I was in that system when I was at Tufts. We were part of the Boston Marathon bombing, and I remember I was actually at the Red Sox that day and with my family, and we were leaving the game and we were going to go down to the marathon, and we ended up deciding not to. Like my younger kids wanted to go home, and so I was like, "You guys are so lame," and thank God we didn't. But,
Yes.
And then before I could even get out of the city, I got a call that the bombs had gone off and that I needed to get to hospital because I was incident commander. And that was a really intense week. And it was, there's a lot of great stories I could tell from that. I know that's not the close to this, but it was a week, right? And it was intense. This was 3 months of being in incident command. And that's something I think from a leadership perspective, it just created, the demands of communication and being able to, clearly make decisions, and then everyone have people know those decisions in real time. The pace of it was amazing. And I think that's something that we've learned so much from, and I just hope we don't, lose some of those learnings over time, because ultimately that relationship with a frontline colleague, you need to develop that trust when things are just completely out of control. And that was a lot of walking around and talking to people that normally, it's interesting because so much happened virtually, yet so much had to happen hands-on. So it's just a really intense time.
I mean, I'm glad you kind of segued into that, because when you think about, again, Boston Marathon 1 week and this being 3 months, but some parallels in regards to learnings that you had that carried with you to really set you up to be able to be a better leader during this time. What are some of the key learnings that you can walk away from saying, hey, this is what I brought with me that really helped well, but these are things that kind of I learned even further and deeper given the extent and the depth and breadth of this pandemic? If you had
it's funny because so a week before the bombing, I had seen, I think the president of New York Presbyterian that was talking about, the flood they had there. And what was that, Hurricane Irma? I can't remember. But, and his big thing was like, you know what, you just got to make decisions. You're not going to have all the information you need. You have to make decisions, and you got to be quick, and that people looking to you to lead. And I remember when I walked out of our first incident command meeting during the bombing, and I walked down to the hallway and I noticed a big population of people in our main lobby. I'm like, what is going on? And I walked out there, and our ED director came out to me and was like, Craig, there's a bomb in the ED. We had to evacuate everyone in the ED. And I was like, oh my goodness. And I could see my emergency management guy off in the foyer, and he was walking towards me. And then the nurse manager for the NICU came to me and was like, Craig, we have to evacuate the NICU because it's right above the ED and there's a bomb in the ED. And I'm like, and there was no bomb in the ED, but
right.
This was the hysteria was going on.
Right.
And so all I was thinking was like, make a decision. And when I saw it, my emergency management guy was like, all clear. And I was like, all right, guys, we're going to go back. Things are okay. We're going to get back into stable. And what was amazing is even as that was going on, you could see doctors and nurses giving direct care to patients in the ED that now was in our lobby, right? And so that was, as I got into this, it was make decisions, Greg, keep the place moving, right? And so there was a lot of decisions got made in the initial days of COVID. What I learned over time was it's making the decision and then making sure that the folks that you work with are responsible for are communicating out those decisions in a real way. So, as a small example, right, we isolation gowns, the yellow paper gowns, you use during, flu season when, patients are on universal precautions. And so on any given week or day, we'd use about 250 isolation gowns per day. And so a week into the pandemic and when we were really high volume here, we had about 100 patients. We were using 3,100 gowns a day.
Oh boy.
And what was happening was everyone was now using this level in this region. And so there became massive supply chain shortages. And so, we had to go to a strategy where, one, we were trying to onboard rewashable gowns so we could reuse them. We were also, because you couldn't flip that switch, and we weren't the only ones trying to do that. We then were, implementing with infection control to reuse gowns, right? And so now here's a gown that you usually walk out and crumble up and throw in the barrel. Now you're being asked to hang it up. We had to go out and buy special hooks and so that things could, air out in the right way. And so, we're communicating all those things, and it was happening in a vacuum. And then, about a week into that, I was walking through the floors, and it was like a war zone, right? There's yellow gowns hanging everywhere. You can just see how stressed the staff was, and it's like, okay, we're not getting out, and we're not being transparent why we're making these decisions that's affecting, frontline caregivers. And to me, that was like such like a slap in the face of like, oh my God, you're great, you're making decisions, but you're not communicating the whys.
Mm-hmm.
And that's making the most important people not trust that leadership is making them safe. And that was hard.
Out of curiosity, you mentioned a little earlier, in terms of communications and learnings, there's Beverly, and then Beverly is now part of, Beth Israel Lahey.
Yeah.
And then obviously there's the broader context of just all the other area hospitals. Was there much conversation, obviously, from Beverly and then getting some learnings from the system itself, Beth Israel Lahey? And then how much did it expand beyond that during this period with talking to Tufts or Brigham? Was it formal, informal?
Yeah, so it's interesting. So there are a couple of comments on that. One, so Beth Israel Lahey Health came together about a year before, a year March, I think was when the system came together. And I'd say that from an organizational behavior or design perspective, Beth Israel Lahey Health did a really good job of saying, okay, we're gonna really be a system here. We're gonna make decisions from a system perspective,
Mm-hmm.
And so they started really pushing a lot of the thought that was happening at some of the bigger AMCs, developing policies and procedures that were system-wide, that then we'd be responsible for implementing. Now, the problem was, right, and this is like the way organizations work, I think, they'd go through a change to an infection control policy. People would discuss it all week long. There was probably drafts being done, and inevitably it would come out as a published policy Friday at like 6:00, which is the worst time you can put out a new policy because there's no leadership here at the weekends. That's one of the hidden secrets about hospitals. Like the leadership structure on the weekends is basically the nursing supervisors, right? And so, that's where we were thankful to get those policies, but we were also able to say, guys, you need to just hold these until Monday morning, or tell us on Friday it's coming, but we're going to
Right.
implement on Monday morning. But we adapted. It's another place where we adapted. So I'd just say, like, the system did a really good job in terms of saying, we're going to be a system and we're going to help you. And I don't know how small independent community hospitals can do it at this point, or could do it through this.
Very tough.
In fact, some of the loosely affiliated community hospitals started to participate in our instant command calls, the system. So all the incident commanders of each of the community hospitals served on an instant command for the system, where we'd share everything that was happening. So that, from a system, was really helpful. The Mass Hospital Association also does a really good job of publishing information around, key shortages, key challenges. One of the big things we've been dealing with now is from the Federal Health and Human Services, just the amount of information that they're requesting of us, right? And so we've been able to work as a system to streamline some of our reporting. We've been able to work with Mass Hospital Association to do the same and get some better definitions. So I think the one thing about healthcare, it's good and bad, right? It's like super small. Everyone knows each other. It's hard to live down some things, but generally you can always make a call to say, hey, how are you approaching this situation? Or, can you lend me this? And people,
Right.
even competing systems are always apt to help. And that's what's really nice about working in healthcare.
I think we definitely have heard similar stories in regards to, newly formed systems. It forced them to come together faster. Yeah. And even not newly formed systems, but those who may not have a system CNO, or may not have, operating quite like a system, really gelled together with this. And I think that there's a positive out of that. And to your point earlier in the conversation, a speed to decision-making, a speed to making things happen. You had no choice. And to try to keep and maintain some of that culture, we hear a lot. Like, how do we make sure we preserve this?
Right.
And I think with that said, in terms of the last question, what are the takeaways? What are the things you think we'll look back on and say, we pivoted during this period and it impacted healthcare in a positive way like we couldn't imagine? What are some of your predictions looking back on that?
I think, there's been a lot of talk over the last 5 years about population health and the move to value, right? This was a population health game changer, right? You think about everything that went to virtual care and how that's going to potentially lower costs. Not only that, people having better access to healthcare, right? Just being able to either telephonically or get on like a call like this, right? And have your medical needs taken care of is a big thing. As a result, we've seen even now we're at about 70% of our ED volume, right? Our inpatient volume actually right now is at about 97% of what we would expect, right? Our surgical volume has actually bounced back to that same level, yet our ED volume is sitting at about 70%. So what it tells me is that, from a population health perspective, some of those visits that didn't need to come to the ED, patients are now opting out, right? So that's really good from a population health perspective. Yeah. We're seeing the same thing strangely. I can't quite put my finger on it, but observation. So inpatient observation, we're not seeing come back at the same level. Again, I think that's related to those lower level ED visits. I think ultimately, long term, it's going to be the other thing I didn't mention, because of virtual care, right? And what was that book that was out probably like 15, 20 years ago, but now The World is Flat, right? And it was the idea that, because of technology, basically places like China, and we're now competing globally. If you think about that from a virtual visit perspective, if I could see someone at the Mayo Clinic, or I could see someone at Beverly Hospital, to the average consumer, they're probably going to pick the Mayo Clinic if they can do that virtually. And so I think it's a real challenge for providers to figure out, what is our value proposition to our patient population, and how do we build on that value proposition? I think access for us will continue to be something that's vastly important, but then also, there is the value of feeling like you have a community resource as your community hospital. And so how do we capitalize on that and meet that kind of virtual relationship with patients, but make them really value what the community hospital gives to them. So we're constantly thinking about that now. So that's sort of my thoughts.
Well, hey, we're out of time, but I can't thank you enough. As usual, very insightful, great learnings, and a pleasure to speak with you, Craig.